In the name of the Allah, systemic TLH, medial to lateral, top down, round, then fold, then bladder, then pedicles, then arteries, then cut, and then lastly close. We will start by round ligament. Start by the round ligament toward the pelvic wall to can catch the round ligament to mobilize the uterus. Coagulate and devise with simple bipolar to open the broad ligament and retroperitoneal. Go toward the bladder flap. Anterior leaf, uterovesical fold to divide the anterior leaf of round ligament by anterior leaf of the broad ligament along to the vesico-uterine fold toward the midline. Start your round ligament coag cut, then go to the second step, which is upper pedicle of adnexia. Start by, if the ovary is removed by lateral salpingio or oophorectomy, you can open the pararectal and paravesical space to identify the ureter as this step, then coagulate and divide the IP ligament. Here, the IP ligament, you need to cut toward the ovary, hug the ovary to go through the another pedicle, which is skeletonization of the uterine artery. Then go to the vesico-uterine fold. Very important tip, which is bladder dissection. Develop the vesicovaginal plane by sharp and gentle traction, counter traction by another hand in the another side by the grasper, then start to go by bipolar and classic scissors, called the scissor here because to avoid any bladder injury, to avoid any vaginal fistula after that. Then you need to dissect the bladder fold and mobilize the bladder below the colpotomizer or colpotomy cabrim. Stay in a vascular plane. Keep dissection on the cervix and the vagina. Keep the dissection on the cervix and vaginal wall. Keep the dissection on the cervix and the vaginal wall. Then go lateral to start to take all of the fold and to take all of the bladder fold. Then go shortly toward the lateral part of the uterus. Very important to skeletonize the uterine artery and developed which is called uterine artery skeletonization of the uterine vessels by divide the uterine artery through the colpotomizer. Hug the uterus here also. Above, hug the ovary to take the IP ligament. Below, hug the uterus to take the uterine artery. Another side, to make the specimen highly mobilized, go to the round ligament, then coagulate the round ligament toward the lateral pelvic wall to leave a short specimen of the round ligament to mobilize the uterus during the operation. Go to the round ligament, coagulate, divide the round ligament to open the broad ligament, ligament as before, which is called gray zone, which is zone underneath no intestinal loop or no important structure. Go to the IP ligament, like this, to see the ureter peristalsis, to see the pararectal paravesical spaces. If you need to go extraperitoneal, you can from here, but this is what's called simple TLH, systematic TLH. So go to the IP ligament toward the ovary, using the cold scissor, simple bipolar, as you see. The more rationale here to take the ovary in a complete way. Rationale here to avoid any high-grade serous ovarian cancer arising from the fempria or distal end. So please, regarding to the guideline, do not let any tubal part, do not let any ovarian part go toward the ovary and tube to completely remove the adnexia pilata salpingo oophorectomy, as you can see. Then you can to protonize and dissect the posterior wall to keep the uterus more mobile, to take the uterine artery in a safe way, to sclerotonize the blood vessels in the very, very easy wall, as you see. Go vertical toward the uterine artery, as you see by the simple classic bipolar and cold scissors. So go through the cold scissors and simple bipolar to take the blood vessels and coagulate and divide at the level of the internal os, medial to the colpotomy rim, please, which is lateralize the ureter. The cup does the ureteric dissection. Very important to know to take the cup upward cephalic and to go to the uterine artery in a vertical part, hug the uterus as you done before in the hug of the ovary, to take the IP ligament. So here, hug the uterus to take the uterine artery. Simple and smooth way to avoid injury to any ureteric part of the ureter, and to avoid any injury during colpotomy and separation of the cervix from the vagina. So very important to know that uterine vessel control and sclerotization by coagulation and the divide close the uterus to minimize collateral damage, as you said. So go toward the colpotomy, circumferential incision at a vaginal fornices using a monopolar or ultrasonic harmonica. Deliver the part of the colpotomizer upward, then go through the colpotomizer at the tip of colpotomizer, not inside, not outside, to make the colpotomy very easy. To make the colpotomy very easy. Incise onto, not into, onto the tip of the cup of the rim circumferentially with the hook, as you see, with monopolar hook, spatula, low pure cut where possible. The cup maintain pneumoperitoneum and bloodless plan. Rotate circumferentially, as you see, using the back of the hook rather than the tip of the hook onto the colpotomizer, onto the cup rim circumferentially with the monopolar hook. Then, as you see, your one hand with monopolar or ligature, one hand with the spatula or with the hook to do complete vaginal separation, to complete specimen division. Go hemostatic. Do not let anything to bleed. Do not let anything to be injured. Don't let anything to be damaged, as a small intestine, as bowel, as large bowel, as the bladder. Go circumferentially, incise onto the tip of the cup. The cup maintain the pneumoperitoneum. Good traction. So a specimen retrieval, deliver the uterus by the vagina toward the vagina. Easy to be delivered, easy and simple TLH. No need any parts of the experience. Just do one, and the candidate do another TLH with simple manner. So we go to the vaginal valval closure and stop closure, stop valval closure and hemostasis. Laparoscopic suturing preferred over vaginal with delay absorbable vicral intracorporing the uterosacral ligament of apical support, McCool type caldoplasty, reduce the vault prolapse, ensure full thickness bites, and include the vaginal epithelium. So go with a hemostatic check, reduce the pneumoperitoneum to 7 to 8 millimeter to unmask venous ooze, that tamponade and hide inside the pedicle, vaginal angle and the bladder and the IP stump, ureteric integrity, very important to concerns, and conformal peristalsis. Maybe need cystoscopy if you need, maybe methylene blue, check the urinary bag. Very, very important. Okay. So as you see, I can go away from the bladder, away from the bladder fascia, away from any fascia anterior to me, away from any peritoneum posterior to me. I take the vaginal vault closure, close the vaginal cuff only, and ensure the hemostasis and restore the pelvic anatomy by a good bites, full thickness bites, to avoid any vault prolapse later on. Okay, very important regarding to the post-operative erase and catheter removal and safety netting, all regarding to the erase guideline by Roy Kolstock, by a recent ACO guideline, which is very important to know about your patient. Key for safety and my rules: identify the ureter before dividing any lateral pedicle, IB, ligament, or uterine artery. Colpotomy cup is your ureteric protector. Seal the uterine artery medial to the rim. Please take the fempria and the tube completely to avoid any cancer later on. Drop the pressure to check the hemostasis. So 4 rules, Hamamsy's rules: identify the ureter before dividing any lateral pedicle, IP, ligament, and uterine artery. Hug the ovary, hug the uterus. The colpotomy cup is your ureteric protector. Seal the uterine artery medial to the rim. Take the whole tube, including the fempria, and the salpingectomy. Drop off the pressure to check the hemostasis. To avoid any vault prolapse, closure of the vaginal fold by laparoscopy, safer than by vagina. Regarding to the recent researches and public researches, which is done in many patients, laparoscopy had many benefits rather than vaginally. Avoid any bladder fascia, any cervicovaginal fascia, any bladder flap, to avoid any nightmares of vasovaginal fistula. Try to take a good bite, try to take the continuous bite, try to take the McCool caldoplasty to avoid any vaginal vault prolapse. Try to remove the needle under vision, try to remove the trocar under vision, try to go with the another part to complete hemostasis, and check the hemostasis by 4 to 8 millimercury deflation of the abdomen to avoid any venous oozing. As you see, please, very important, many patients had open laparotomy post-operative after TLH because venous blood. So try to keep dry, try to keep safe. Easy peasy, lemon squeezy, Hamamsy schmeezy. Bye bye.